Welcome back to Pediatric Advanced Life Support. In this lecture, we will be covering respiratory emergencies in pediatrics. So first, it's important to learn about the anatomic and physiologic considerations that are unique to children versus adults. Firstly, it's important to note that children have a relatively larger head than adults for their body size, and in particular they have a larger occiput, which is the back portion of the head. This is significant because when you are placing a child supine or on their back on a table, as is necessary sometimes in the course of PALS administration, this changes their airway position. It can actually make it so that the airways are not fully open, and so it's important to realize that optimal airway positioning is important to maintain a patent airway and keep a child having good oxygen exchange. Secondly, it's important to note that head bobbing or movement of the head can be a sign of increased work of breathing in children who are in respiratory distress or respiratory failure. Secondly, children have relatively smaller nasal passages than adults. And this is significant because some children are known as obligate nasal breathers, and that is they do the majority of their oxygen exchange through their nose versus through their mouths. This is also significant because children with respiratory illnesses, such as viral illnesses, including bronchiolitis, can have their nasal passages clogged by secretions or mucus. And so knowing to keep the nares open and patent is an important step. Additionally, children have relatively larger tonsils and adenoids in their early childhood ages, and so that can cause some degree of airways obstruction in children with respiratory distress. Finally, children are known to have a relatively larger tongue than adults for their mouth size, and this is particularly true in some children and those with trisomy 21, as they have macroglossia or a large tongue, which can obstruct their airway. Additionally, when children are lying on their backs in the supine position, the tongue can actually fall back into the mouth and obstruct their airway significantly further. So this is important information to keep in mind. Next, we'll look at the larynx and the trachea, which are the upper airway of the children beyond the area of the mouth. Now this diagram displays the cartilages of the larynx, which include the epiglottis, which is significant in a particular infection we will talk about, and then the thyroid and cricoid cartilage. And these are essentially the landmarks if you ever need to bypass an upper airway obstruction versus cricothyroidotomy. You can see on the right we have a diagram of the vocal cords. So the vocal cords open and close in the course of respiration and phonation or speaking. And so that is what they will look like if you are performing an endotracheal intubation. Next, anatomic considerations for children regard the chest and the lungs. So of note, children have a relatively thinner and more pliable chest wall than adults, and they have relatively more immature and weak intercostal muscles than adults. So that means that children don't have as strong respiratory musculature in order to breathe harder against resistance or increased pulmonary or decreased pulmonary compliance in lung disease, and so they have less pulmonary reserve. Additionally, children have a different physiology versus adults. So they have a higher metabolic rate, that is, they need higher rates of energy to perform the bodily functions required to sustain life, and they have a higher oxygen requirement per kilogram of body weight. This is compounded by the fact that children have smaller oxygen reserves in their lung volumes. So there are several different volumes that we consider in terms of oxygen exchange, and one of these, known as the functional residual capacity, acts as an oxygen reserve and can be filled with 100% oxygen when you're pre-oxygenating in the course of resuscitating in children. But it's important to know that this is a relatively smaller volume in children versus adults. So even if you pre-oxygenate and fill that space up with 100% oxygen, they will deplete that oxygen relatively quicker than adults. And so children will desaturate quicker when they are in respiratory failure or respiratory arrest. And so it's important to keep this in mind and move quickly when resuscitating and treating these children. Next, we'll look at the definition and components of respiratory compromise. So, respiratory distress is the first element of respiratory compromise, and this is essentially defined as increased work of breathing and a respiratory rate outside the range of normal for age. Now, there are different signs and symptoms that are important to be familiar with in terms of respiratory distress in children. The quality of their breaths can change, and they can breathe deeper, known as hyperpnea, or more quickly, known as tachypnea. They can also exhibit different breath sounds. Usually a healthy patient will have clear breath sounds. In a child with respiratory distress, they can have different breath sounds, which usually indicate the flow of turbulent air through narrowed passageways. So if this is turbulent air through lower airways, this can be defined as wheezing. And if it's turbulent airflow through an upper airway, this is typically called stridor. And both of these can happen in the inspiratory and expiratory phase of the breath. Next, we can look at the accessory muscles of the child as indications that they are in respiratory distress. These begin at the nostrils and can be demonstrated as nasal flaring or kind of outpouching of the nostrils when a child is working harder to breathe. Next, we look down at the chest and we can see what's known as retractions. So retractions are essentially sucking in of the skin and soft tissue between bony structures when a child is generating a larger interthoracic pressure trying to catch a breath. And so this can happen supraclavicularly above the clavicle, it can happen intercostally in between the ribs, it can happen subcostally in the abdomen. Looking at the abdomen, we can also see something known as seesaw or paradoxical breathing. And this is essentially where the chest and the abdomen move in a paradoxical pattern. So one moves in and one moves out. And this is a sign that a child is using a tremendous amount of negative pressure to draw breath into their chest and is a sign of severe respiratory distress. In terms of systemic signs of respiratory distress, we can also look for things such as cardiovascular compromise indicated by tachycardia or elevated heart rate. We can look for altered mental status, which presents more subtly as irritability or anxiety. And then we can look at their general oxygen delivery to their body. So if a child is pale or has pallor, or if they're mottled, meaning purplish or reddish in a kind of lacy reticulated pattern, this can mean that their body is not receiving adequate oxygen. And this is also sometimes demonstrated by central cyanosis, which is a bluish discoloration of the skin over the trunk and abdomen regions. So when working with a child in respiratory distress, it's important to approach the child promptly but calmly so as not to scare them and agitate them further. We always like to permit a child to assume a position of comfort, which is usually in a parent's arms, so that they can remain calm and decrease their work of breathing as much as possible. Additionally, we try to correct their hypoxia if it exists without causing agitation. So, nasal cannula is non-invasive, but even less invasive can be things such as blow-by oxygen, if that's sufficient to raise their oxygen saturations. And then you'll provide further care based on your assessment and how the child responds to the interventions that you try. So respiratory failure is next on the gradient of respiratory compromise, and this is defined as inadequate oxygenation or ventilation to meet the metabolic demands of the body. And so just to review, oxygenation is delivery of oxygen and ventilation is removal of CO2. And both of these processes need to be accomplished in the course of the breathing cycle. So respiratory failure has significant and unique signs and symptoms as compared to respiratory distress. So the quality of the breath can be changed in terms of patient have tachypnea, as we said earlier, but also patients that are tiring out or having more severe respiratory failure can actually have slower breathing or bradypnea, even progressing to apnea or lack of breathing in late phases of respiratory failure. These patients have retractions. They have accessory muscle use. So in addition to retractions, which is sucking in of soft tissue around the ribs, accessory muscle use can be manifested as using extra muscles apart from the intercostal muscles to draw breath. So sometimes patients will engage their sternocleidomastoid muscles. They use their nostrils and nasal flaring, as we already said. And the use of these muscles is a sign that these patients are really working hard to breathe and exchange oxygen. In patients with more severe respiratory failure, they can have decreased effort or tiring out, and additionally decreased chest excursion. Now, the systemic signs of respiratory failure are similar and more severe than those of respiratory distress. So patients can have more severely altered mental status or lethargy. They can have a weak or absent cry. They can be tachycardic or even bradycardic, which is a more ominous sign, bradycardia being a slow heart rate. As we said, they can have central cyanosis, mottling, or hypoxemia, which is not responsive to oxygen administration. Additionally, their neurologic status can be an indicator, and they can have hypotonia or low body tone, particularly in babies and infants. So what we do for a child in respiratory failure is we move more quickly. We try to open the airway, and that brings us back to the considerations about pediatric anatomy. So the best way to open an airway in a child is to try to put them in something called the sniffing position. If they're lying on a table in the supine or on their back position, you try to essentially tilt their chin up and put their occiput back, so it looks like they're sniffing, trying to get a whiff of a flower. And this will help essentially put their airway in a more inline position, and sometimes move their tongue out of the back of the throat as well. Additionally, another easy way to open the airway is to suction out secretions if there's extra secretions in the course of an infectious illness, and this can be done with a suction catheter. Next step, as we know, is providing supplemental oxygen, whatever means that you have available. And then if a patient doesn't respond, or if they're having bradypnea or apnea, you may have to use bag mask ventilation techniques, which will be demonstrated in your skills stations. Next levels of support beyond bag mask ventilation or bagging would be the use of either non-invasive or invasive positive pressure ventilation. Now, the signs of respiratory arrest, which is the most severe part of the spectrum of respiratory compromise, are essentially absence of breathing. And these patients will have absent chest wall motion and absence of breathing effort. Their tachycardia has at this point progressed to bradycardia, which can progress to asystole, or the absence of a heart rate. We know that they can be hypotonic, as we said before, and they can have severe mottling and cyanosis throughout their body because they're not getting adequate oxygen delivery. They will become unresponsive, and they will have signs of cardiovascular compromise, including weak or absent pulses, particularly if they're having asystole. So obviously in these situations you have to move quickly. You have to open the airway with an airway maneuver, such as putting the child in a sniffing position. You can also achieve this and put the airway in a more inline position by sometimes putting a shoulder roll under the back of their shoulders, so that their large occiput is not occluding their airway and putting them in a chin down position. You should always suction the airway to remove excess secretions, and then if that does not result in improvement of oxygenation, you need to begin ventilation with a bag mask device. It's important to reassess periodically as you're doing these interventions to see if a child has improved spontaneous respirations or improved hemodynamic status after your interventions are performed, and then you'll need to escalate care as needed. So getting into the different etiologies or different kind of processes behind respiratory failure and everything else on the spectrum, we'll look first at upper airway obstruction. So upper airway obstruction can be caused by many things. First and foremost can be nasal secretions in patients who have infectious illnesses. Next, we'll look at airway swelling, and there's different types of that, including Croup, Epiglottitis, and Anaphylaxis. Upper airway obstruction can be caused by foreign body obstruction. And then there are also certain types of congenital airway abnormalities which can cause upper airway obstruction. So the signs and symptoms of upper airway obstruction are changes in breath sounds. The first we'll talk about in a particular illness can be manifested as a barking or seal-like cough. These children who have upper airway obstruction or swelling can have a hoarseness to their voice. And then they can also have stridor. Now stridor can be present on inspiration or expiration, and that depends on where it is in the airway and if it's amenable to certain airway maneuvers. Now this is just the sound of turbulent air passing through a narrowed airway or a narrowed passage. These children can additionally have signs of increased work of breathing, which we mentioned, and include retractions, nasal flaring, or tachypnea, or fast breathing. So the interventions that we should do for children with upper airway obstruction is firstly put them in a position of comfort, as agitation can severely worsen turbulent airflow and agitation can worsen a child's work of breathing. You need to try to open the airway if necessary or possible. So make sure they're not crunched over, make sure that they are upright and in a sniffing position if need be. And then you will want to assess briefly for the presence of a foreign body. Now, sometimes this can be seen by a superficial inspection of the oral cavity, but sometimes may need more invasive techniques to discover a foreign body. Finally, as we said before, nasal secretions can cause significant upper airway obstruction, so you need to suction the nose and mouth of a child if it appears that they have significant drooling or secretions that are obstructing their upper airway. You'll always want to perform a thorough assessment, including application of a pulse oximeter, a cardiac monitor, and obtain a blood pressure, as respiratory compromise can always cause cardiovascular compromise. Next, for interventions, if you are having upper airway obstruction secondary to you think a tongue obstructing the airway or decreased tone of the airway, there is a technique known as using an oral airway, which can open up a patient's oropharynx. And that gets back to the point we talked about a child's special anatomy. So children having large tongues that can sometimes fall to the back of their throats and obstruct their airways can be moved out of the way with something known as an oral airway. And essentially this is a C-shaped piece of plastic which is placed in a child's mouth and pulls the tongue down and out of the way of the oral passage. And so children can sometimes tolerate an oral airway if they are unresponsive. On failing this, there is also something known as a nasal airway or a nasal trumpet, and this is placed in one of the nares of a child who is in the respiratory distress and can bypass a lot of the upper airway obstruction from oral tissues. So these are important techniques to remember if you have access to them. Secondly, you should administer supplemental oxygen, as this can sometimes improve saturations despite airway obstruction. And if you think you're going to need more invasive techniques or therapies, you will probably need to establish IV access. Now, the first specific syndrome associated with upper airway obstruction that we'll talk about is known as Croup, or laryngotracheobronchitis. And so this is inflammation of the laryngo, tracheo, and bronchial tissues, as the name suggests. This is typically seen in children that are aged 6 months to 6 years. And it is essentially a manifestation of swelling of the mucosal and submucosal tissue at the level of the cricoid ring. And that gets back to those cartilages we mentioned earlier in our talk. These children generally present with a prodrome or a few days of upper respiratory tract infection symptoms such as cough and fever. And then they progress to more severe symptoms such as hoarse voice, stridor, and a barking or seal-like cough. They can additionally have ongoing fever due to their viral etiology. So croup care is typically determined by the severity of the disease. And so mild croup is essentially managed by an initial assessment and focused history, which may reveal that viral prodrome progressing to worsening stridor and barking cough. You'll want to get their oxygen saturations and place them on a cardiac monitor. And then it's important to, again, keep them calm and comfortable and give supplemental oxygen if needed. Now with croup, as it is a inflammatory process causing swelling of the upper airway, the administration of systemic steroids can often be very helpful in these patients, and if it's mild, they can often tolerate oral steroids, and this can be enough to get them feeling better in discharge tone. Now in patients with moderate to severe croup, again, you'll want to put them on a monitor and check their pulse ox to make sure their oxygen saturations are sufficient. And then if they are having severe upper airway obstruction or stridor, it is worth trialing a medicine known as nebulized epinephrine. And so epinephrine, when delivered in a nebulized form and directly exposed to those swollen airway tissues, can actually cause vasoconstriction and decreased swelling of the swollen tissues. And so patients who respond to epi, or racemic epinephrine as it's known, often will have a very rapid response. Unfortunately, it's also very short-lived, so these children may require frequent treatments or intensive care for the level of monitoring they require. Additionally, as we said before, because it's an inflammatory process, they may respond to systemic corticosteroids, either oral or sometimes IV if it is more severe. So in these patients, if they do develop signs of respiratory failure, the ones we mentioned earlier, they will certainly need supplemental oxygen, and beyond that, perhaps bag mask ventilation or more invasive mechanical ventilation. The next phenomenon we'll talk about is known as epiglottitis. And so epiglottitis is exactly what it sounds like. It is itis, or inflammation of the epiglottis tissues. And this is typically caused by a bacterial infection, and its diagnosis is usually made based on a history and a clinical syndrome, which we'll talk about. So these patients usually present with a history of a viral prodrome, but then progressing to more ominous symptoms such as drooling or inability to manage their secretions, dysphagia or difficulty swallowing, and respiratory distress, or just distress in general. These children appear more acutely ill or toxic than children with less severe illnesses. And one telltale sign can be that they prefer to sit up and lean forward with their mouth open. And essentially what a child is doing in this position is called tripoding. And that's by them leaning forward, allowing their tongue and oral tissues to fall forward and actually perform somewhat of an airway maneuver on themselves, thereby relieving some of their upper airway obstruction. One of the prototypical signs that we also hear about in textbooks is something known as a muffled or hot potato voice. And because of the swelling of their epiglottis, this hot potato voice can be a manifestation of that. So something to look out for in your scenarios. So for a child who presents with epiglottitis, you have to observe them very closely and reassess frequently, as they can have progressive swelling of the epiglottis and closure of their airway entirely. Of course, we always want them to assume a position of comfort so as not to worsen their agitation and their upper airway obstruction. And it's important to disturb them as little as possible and not let them take anything by mouth, primarily because they may have trouble swallowing, and it may not be physically wise to allow them to put anything in their esophagus, as they have a risk of aspiration. And additionally, if they need invasive mechanical support, you don't want them to have a full stomach, complicating your intubation process. Next cause of upper airway obstruction that we'll discuss will be foreign body aspiration. And so foreign body aspiration usually occurs in children that are between 9 months and 5 years of age. And this is from the time that these children become mobile and are able to get into more trouble and put things in their mouth, and up until the time that they develop the common sense not to do so. And the prototypical story for this scenario is where a child is playing and completely healthy without a viral prodrome, and then all of a sudden develops signs of upper airway obstruction while playing or eating or something of that nature. These are some of the items that can cause upper airway obstruction, small items, things that are easily lodged in a child's mouth, and scary things for any pediatrician. So when managing these children, it's important not to agitate them if they're conscious, maintaining their own airway, and coughing. We always allow that child to assume a position of comfort. If they need oxygen, you can always provide it if it does not agitate the child further. And then, it's important to let that child cough and continue to cough, because that natural reflex may actually be enough to dislodge the foreign body if you're lucky. Now, if a child progresses from a foreign body partial aspiration causing partial obstruction to a full upper airway obstruction, and your child becomes unconscious or cannot make any sound, then you need to proceed to maneuvers to try to dislodge the foreign body. And so in adults, this is known as the Heimlich maneuver, but in children we have two separate maneuvers which we can perform. And so in a older child greater than 1 year of age, you can perform abdominal thrusts, not pictured here. And so this is similar to the Heimlich maneuver, where you perform a large positive force by thrusting your fist in a closed fist fashion over a child's abdomen, thereby hoping to dislodge the obstructing object. Or if you have a younger child who is smaller than 1 year of age, you can put them on your knee or your leg with their head in the downward position, and then perform vigorous back slaps and chest thrusts. And sometimes this is sufficient to dislodge that object that is obstructing the airway. The next phenomenon that we'll discuss in terms of upper airway obstruction is that of anaphylaxis. And so anaphylaxis is a severe allergic reaction which happens within minutes of an exposure to an allergen for that particular child. And the most common causes that we see in medicine are those from insect stings, including bees and wasps, exposure to things like latex, medications, either known or unknown medication allergies, the most common ones being the penicillin family and sulfonamides as well. And then food allergies are a big player as well, and the most common ones being peanuts, tree nuts, wheat, soy, eggs, milk, fish, and shellfish. Those are the big 8. And so anaphylaxis, defined as involvement of 2 or more body systems in an allergic reaction, is manifested by these signs and symptoms. So the patients will often have tachycardia or fast heart rate and hypotension or low blood pressure. This is because of the anaphylaxis and the allergy causing vasodilation. Their breath sounds may change as well, and they may have signs of respiratory distress or respiratory failure, including retractions. They may have stridor or wheezing, indicating narrowing of their airways and their bronchioles or upper airway, and they may have coughing as well. The systemic signs that we see in terms of anaphylaxis can be many. Children can have anxiety or restlessness as signs of altered mental status. They can develop severe full-body rash or pruritus with itching. That also translates into hives or urticaria. They can have warm and flushed skin because they are having vasodilation. They can have swelling of their face and lips, difficulty swallowing or hoarseness, and then GI symptoms as well can be a sign. So abdominal pain and vomiting or diarrhea are known symptoms of anaphylaxis with GI involvement. So first steps of assessment is, of course, applying a pulse oximeter and cardiac monitoring. And then interventions are simple. You need to remove or discontinue the causative agent if it's still in play. So if there's a stinger in the child, or if they are still touching an object that they are allergic to, obviously you need to discontinue this. You can administer supplemental oxygen if the child is hypoxemic. And then the real treatment for anaphylaxis is intramuscular epinephrine. This can be administered in the form of an EpiPen if the child has one, or from a pharmacy in your medical area. The best place to administer this is in the anterolateral thigh because it has the lowest chance of hitting vascular structures or nerves, causing damage, and has a good absorption from that area. Additionally, patients can receive albuterol for bronchospasm if that is one of the manifesting signs of their anaphylactic reaction. Additionally, if the patient does not initially respond, or if they're going to need further observation, it's always important to obtain IV access. And this is so we can provide ancillary treatments past IM epinephrine. So these patients may benefit from IV antihistamines such as Benadryl or diphenhydramine, H2 blockers, another type of antihistamine agent. IV corticosteroids are often used, and then fluid resuscitation if a patient has anaphylactic shock or hypotension with their vasodilation. So that concludes our section on upper airway obstruction. We'll move now to lower airway obstruction. The first syndrome associated with lower airway obstruction is asthma or reactive airways disease. And so this is, by definition, a lower airway disease which is characterized by several things. Chronic bronchial inflammation is a hallmark of this process. So the bronchioles, being the lower conducting airways of the lungs, are chronically inflamed. And then they're also what's known as hyperreactive. And so that means by when they are triggered by certain entities, including infections or allergens, this can cause reactivity or episodic bronchospasm. So episodic means it happens sometimes. Sometimes the airways are completely patent. Sometimes the airways are clamped down. And it all just depends on what state of inflammation that airway is in and how reactive it is. And bronchospasm just means spasm or contraction of those airway muscles around the bronchioles. It is an obstructive disease process. So what that means essentially is that you have difficulty getting air out of the lungs, but not necessarily getting air into the lungs. And so that's an important distinction to make, and important when you're thinking about the treatment for asthma. The signs and symptoms of asthma are many, but the typical ones that we see are changes in your breath sounds. Of course, you can have cough with early or mild asthma. They can have poor aeration, so decreased breath sounds. They can have a prolonged expiratory phase compared to their inspiratory phase of the breath. And then they almost always have wheezing. So wheezing being that sound of turbulent airflow through bronchioles or lower airways. When they have respiratory distress, again, you'll see these signs of accessory muscle use, such as retractions and nasal flaring, and then they'll always have systemic signs on top of that. So tachypnea, hypoxia, altered mental status, difficulty breathing on exertion, and just subjective chest tightness as well. So in mild asthma, these patients have relatively preserved ability to talk in full sentences. They may be somewhat agitated, but can lie down without great discomfort. They certainly will have dyspnea with activity, but they may be breathing faster than normal and have some mild or moderate end expiratory wheezing, so at the end of the expiratory phase. Now with more moderate severity asthma, they may be able to talk in phrases but not sentences. They may not feel like laying down, as it's difficult to catch their breath in that position. They may be more agitated. They may still have tachypnea, and they may have, instead of just end expiratory wheezing throughout the course of expiration. In severe asthma, these patients often become severely breathless at rest, unable to speak at all. They prefer to sit upright or in this hunched forward or tripoding position we mentioned earlier. They may become very agitated or even lethargic if they're retaining carbon dioxide or difficulty getting oxygen. They certainly will be using more accessory muscles, and they can either have a very increased respiratory rate or, more ominously, a decreased respiratory rate with long, deep, slow breaths and difficulty getting air out. And again, you can have wheezing not just through the expiratory cycle of the breath now, but also with the inspiratory cycle, really indicating a very narrowed airway. And then an important caveat to all this is that if you don't hear wheezing, that's not necessarily a good sign. If a patient has a quiet chest and a severe asthma exacerbation, that may indicate that they're not moving any air at all, and that can be something preceding a respiratory arrest and is very ominous and a cause for concern. So these are the signs of imminent respiratory arrest that I alluded to. So drowsiness or confusion and altered mental status, slow heart rate, and quiet chest or absence of wheezing can be signs that you're about to have an arrest. So the way we treat asthma is we do our initial assessment and obtain a focused history as to what triggers and what may have brought this on. You of course want to put them on a pulse oximeter and a cardiac monitor, and as always, allow them to become. Sometimes useful is a peak expiratory flow rate meter, typically used in the outpatient settings, but this is good to compare against a child's baseline if they are compliant with this exercise. And first steps for treatment generally are giving supplemental oxygen if need be. If a child is having difficulty maintaining respiratory effort, you can use bag mask ventilation. It's important to assess their hydration status because children who have had an asthma exacerbation going on for some time have likely been tachypnic and not able to drink sufficiently to keep up with their insensible losses, so they may be quite dehydrated. And additionally, the exposure to albuterol can cause low blood pressures, especially when giving in continuous form. So you want to make sure that a patient has good intravascular volume status when they present this way. To do that, we obtain IV access, because you may need to give them fluids, and additionally they may need IV medications to treat this exacerbation. The treatment, the cornerstone of treatment for asthma is bronchodilators, such as short-acting beta-2 agonists, and this is typically albuterol. This is the medicine that reverses the bronchoconstriction. It opens up those inflamed airways and causes relief of the obstructive process that you're seeing as the hallmark of asthma. Additionally, because it is an inflammatory process, you'll want them to get corticosteroids as often and as early as possible. So when you give corticosteroids, you often see the response, hours later, so you want to get them in the patient as soon as possible when they present. Now, with more severe asthma exacerbations, there are additional nebulized therapies we can use. Albuterol can be delivered by a metered-dose inhaler or a puffer, or a nebulizer machine if a patient is in the inpatient setting and cannot adequately perform their inhaler technique. Additionally, there are other bronchodilators, including ipratropium, which works by a different mechanism, but essentially reverses that bronchoconstriction process. Patients with asthma also respond to systemic therapies such as IV steroids, a step up from the oral steroids we talked about previously. And then there are other smooth muscle relaxing agents such as magnesium IV, which essentially just relaxes all smooth muscle in the body and is sometimes used as a second or third line agent in these patients. Now, patients with asthma who have respiratory failure or respiratory arrest may sometimes require endotracheal intubation. This is a high-risk proposition, unfortunately, because it has to be performed by a skilled operator. And then because of the very nature of asthma, where it's a process where you have bronchoconstriction and difficulty getting air out rather than air in, putting a patient on a positive pressure ventilator necessarily isn't a great idea. This can cause complications such as air leak or pneumothorax with air leaking outside the lung. And then with severely increased intrathoracic pressures, as we see in asthma, it can cause decreased preload to the heart and cardiac arrest, which is obviously an emergency. So we try to avoid intubation and use non-invasive techniques of respiratory support if at all possible. The next disease process that we'll discuss is known as bronchiolitis. And so bronchiolitis is just what it sounds like. It's an acute infection or inflammation of the bronchioles, which is the lower conducting airways of the lungs. Now, the most common cause in children is a virus known as respiratory syncytial virus, or RSV. And this is a process that usually occurs in children from birth to about 3 years of age. It is atypical to see it outside of this age range. Now, children who present with bronchiolitis typically have a viral prodrome of a few days, which is fever, cough, runny nose, progressing to more severe coughing and wheezing. These children can also become dehydrated because they're coughing and not able to maintain good oral intake. They may have fevers causing increased insensible losses. So this is typically what ends up getting them in the hospital. So for treatment of these children with bronchiolitis, you want to always allow them to assume a position of comfort, suction the nares of secretions and try to clear them if possible, and then initiate pulse oximetry and give them supplemental oxygen if they need it. You want to ensure adequate fluid intake, and so whether that's by mouth or IV, you need to make sure that children are well hydrated because that keeps their secretions clear and prevents them from becoming too viscous and sticky and difficult to cough out and clear. These children will require close monitoring. If they have severe bronchiolitis, likely they'll need to be observed in an inpatient setting. And occasionally, in more severe and moderate cases of bronchiolitis, we do trial bronchodilators such as albuterol and racemic epinephrine, as they have a inconsistent benefit in these children. The next category of diseases we'll discuss in our lecture is those of the lung tissue itself. So moving on from airways, we'll move to the lung parenchyma. So the first category and the first disease process we'll look at is known as Bronchopulmonary Dysplasia. And so BPD, as it's known, is a chronic lung disease secondary to prematurity of the lung parenchymal tissues. And so parenchyma just means those tissues in the alveoli, or the small bubbles at the terminus of the lung conducting airways that exchange oxygen between the lungs and the bloodstream. And so children with BPD are defined as those who require treatment with supplemental oxygen greater than 21% FiO2 for at least 28 days after birth, and or those who require positive pressure ventilation at 36 weeks of postmenstrual age. And so typically these are children born prematurely who have immature lung development and do not have the parenchymal reserve to perform oxygen exchange without some level of support. So the signs and symptoms of BPD, the underlying process, as we already spoke about, it is a parenchymal lung disease, so it involves those alveoli, but it also involves some degree of bronchospasm or constriction of the conducting airways, and then mucus plugging as well, and difficulty clearing secretions. So because of that underlying process, the exam findings that we typically look for would be tachypnea or fast breathing, cough, crackles or ralls on exam, and then signs of respiratory distress such as retractions, wheezing, and indicating turbulent flow through the airways. Assessing the child with bronchopulmonary dysplasia follows the same pattern as before. We always want to make sure we avoid agitation, allow them to be comfortable, and then monitor their pulse oximeter and see what their oxygen saturations are. There are varied therapies for children with bronchopulmonary dysplasia. Because it's a parenchymal lung disease with airways involvement, they do sometimes respond to bronchodilators. There is also a certain inflammatory process, so corticosteroids are sometimes useful. And then because patients sometimes develop extra lung water or pulmonary edema, as we'll discuss later. They can sometimes benefit from diuretic therapy. And finally, because some PPD exacerbations are caused by bacterial infections, there is some course for antibiotics from time to time in these patients. The next disease process that we'll touch on is known as cystic fibrosis. And so CF, or cystic fibrosis, is an inherited disease which is caused by a gene mutation resulting in the production of abnormally thick and sticky mucus that can affect multiple organs in the body, but most notably the lungs, as we'll talk about today. So you can see in a normal airway, you have a large patent airway which has a thin layer of mucus lining it to keep it moist and hydrated. But in CF, you have a very widened airway as a result of chronic plugging with viscous mucus, and this mucus actually becomes a haven for bacteria, causing recurrent and severe bacterial infections. And these patients have a chronic disease process which is difficult to manage. So the signs and symptoms of a pulmonary exacerbation of cystic fibrosis include general systemic signs such as fatigue and fever, and then signs of respiratory distress, including accessory muscle use and cough, productive of thick, viscous sputum. So it's important to always have the consultation of a pulmonologist first in the care of patients with CF as a starting point for these patients, because they will need special attention when they're admitted to the hospital. Of course, these patients, we'll want to keep them comfortable, monitor their oxygen levels, and provide oxygen as needed. IV access for hydration is very important, as the thick viscous mucus that we spoke about does improve with adequate hydration. And then therapies that are a hallmark of CF treatment include CPT, or chest physiotherapy. And this is basically percussive therapy where by beating on the chest and kind of loosening and helping clear those secretions, you can severely improve lower airways obstruction. Additional medications that we sometimes use in the treatment of CF include nasal decongestants, bronchodilators to open up those airways, mucolytics, which are medications which help break down and clear mucus, and then corticosteroids because of the chronic inflammatory process, and antibiotics because of this chronic and recurrent bacterial infections that we often see. The next process that we'll touch on is pneumonia. So pneumonia is one of the more common causes of a lower respiratory illness in children after bronchiolitis. And it can be due to a number of different pathogens, including viral, bacterial, parasitic, or fungal organisms. It can occur as a primary infection, or it can occur secondary to another illness. And the hallmark of this is the infection of Staph aureus pneumonia, sometimes associated with influenza, lower respiratory tract illness. And so pneumonia is usually manifested as an upper respiratory infection progressing to more severe signs. Discuss. So the signs and symptoms are nonspecific, but include cough, diminished breath sounds, pleuritic chest pain, which is pain when taking a deep breath. Also can have shortness of breath, fever as a sign of systemic or severe bacterial infection, and then malaise or fatigue. On your physical exam, you will usually have hypoxemia if there is any element of parenchymal lung disease, and then signs of respiratory distress such as nasal flaring, retractions, and tachypnea. So for patients who present with pneumonia, it's important to make them comfortable, monitor their oxygen levels, and provide supplemental oxygen as needed. As is typical with these respiratory infections, you want to assess their hydration status and obtain IV access if necessary. Some patients with pneumonia may have some bronchospastic process and will respond to albuterol. And then the hallmark of treatment for bacterial pneumonia would be antibiotic treatment. You can usually make a good educated guess of what bacterial pathogens could be involved based on where the patient is coming from, whether that be from the community or the hospital setting. But antibiotic therapy will go a long way in treating bacterial pneumonias. And then antipyretics are a nice ancillary therapy as well, antipyretics being medicines that decrease fever. All right, the next disease process we'll be discussing is known as pulmonary edema. So there are different flavors of pulmonary edema. The first type we'll be discussing is known as noncardiogenic. And so noncardiogenic pulmonary edema can result from a number of different things. This can happen from trauma in the setting of acute head injury. This is something known as neurogenic pulmonary edema. And due to CNS injuries or central nervous system injuries, this can actually cause a remote increased permeability of the blood vessels or the pulmonary capillaries in the lungs, causing essentially movement of fluid from the capillaries into the lung space. And that's what causes pulmonary edema in the setting of trauma or head injuries. Additionally, pulmonary edema can happen after aspiration or inhalation of fluid into the lungs. It can happen in the setting of high altitude exposure, so patients who travel to high altitude and perform strenuous activity can develop pulmonary edema during mountain climbing or other activities. And then it can also happen from aggressive fluid administration for other disease processes. Finally, pulmonary edema can happen secondary to drowning processes. The second flavor of pulmonary edema to discuss is known as cardiogenic pulmonary edema. And so cardiogenic pulmonary edema essentially means that you have extra fluid in the lungs because the left side of the heart, which typically pumps fluid out of the lungs and transmits it to the body, is not functioning properly. And so this can happen for multiple different reasons. If a patient has any type of left-sided heart disease, including congenital heart disease or heart disease that they are born with, if they have myocarditis or inflammation of the heart muscle, if they have any heart valve disease on the left side, including mitral aortic valve disease, this can happen. If they have any inborn cardiomyopathies or abnormalities of development of heart muscle, and if they're on any medications that depress cardiac function, this can cause pulmonary edema as well. So treatment for this is consistent with the other disease processes we've seen. You want to make sure the patient is comfortable, monitor them very closely, their oxygen levels and their cardiovascular status, administer supplemental oxygen as needed, and then advance their care to mechanical ventilation or invasive mechanical ventilation as needed. Because pulmonary edema is a process that can be caused by excess fluid load, you can often use diuretics with good effect. And then if your pulmonary edema is caused by left-sided heart dysfunction, sometimes vasoactive medications or medications that improve the function of the left side of the heart can improve your pulmonary edema. All right, next we'll be looking at disorders of ventilatory control. So disorders of ventilatory control start off with increased intracranial pressure. And so increased intracranial pressure can result from dysregulation of your cerebral blood flow. And we know that adequate blood pressure, systemic blood pressure, is critical for brain perfusion. And there are situations where the cerebral autoregulation or delivery of blood to the brain can become impaired. And this can happen for multiple different reasons. In the setting of trauma with cerebral edema or brain swelling, that can cause increased pressure in your head, causing decreased blood flow into that space. And then in setting of hypotension in the body, you can have decreased blood flow to the brain, obviously, because the brain is one of those end organs being perfused by the body. Trauma is the most common cause of increased intracranial pressure in pediatric patients. So the ways we look for increased intracranial pressure in infants would be things such as a high-pitched cry as a prototypical sign, an irritable baby, a baby with distended scalp veins can be a superficial indicator of increased intracranial pressure. If the patient is having vomiting, don't always think of GI causes. This can reflect intracranial processes as well. If they're not feeding well, and then if they have a tense or bulging fontanelle, the fontanelle is the opening in the skull which is not yet fused, and this is a good window into the intracranial status of a patient and what their intracranial pressure might be. Now in an older, more verbal child, you can get a little more information about signs of intracranial pressure. They may describe things such as blurry vision, a headache. They may be unable to follow commands. They may complain of vision loss even, have seizures, or present with altered mental status, progressing from restlessness to irritability to lethargy later on. So increased intracranial pressure can affect your respiratory status, and we know this because of the pressure in the intracranial space affects the brainstem, and the brainstem controls your breathing drive. So these patients, obviously you need to ensure adequate oxygenation and ventilation and perfusion because you need oxygen delivery and you need perfusion to your brain as well. So put them on a monitor. Pulse oximeter and capnography is a good way to measure end-tidal CO2 or exhaled CO2. and then these patients will likely need IV access. Because we're likely in a situation with a neurological, neurosurgical problem or a trauma situation, you'll want to perform neurological checks with their vital signs. And then there are many different ways you can reduce intracranial pressure, but the most readily available to us include the administration of either hypertonic saline, which essentially draws fluid out of the brain tissue, or other osmotic agents such as mannitol, which can decrease the amount of intracranial pressure by drawing fluid out of those brain tissues and into the vasculature. All right, the next category we're going to look at is that of neuromuscular disease. So neuromuscular disease is important because any neuromuscular disease will affect the muscles in the body, including respiratory muscles. And as it would make sense, respiratory muscle weakness can affect your breathing. That's all we're going to say about that. Next category is acute poisoning or drug overdose. So acute poisoning or drug overdose is a common cause of admission to the ICU for children. And there are many types of toxidromes or syndromes from toxins that can cause respiratory failure. And so it's important to be familiar with the certain toxidromes out there from commonly exposed medications. And when you're admitting a patient or seeing a patient present with a possible toxidrome, it's important to get as much information regarding the type of exposure, how much medicine they may have taken, and what you're dealing with exactly. So these presentations can vary widely and cause changes in a patient's hemodynamic status, their respiratory status, and their temperature regulation. So if you're seeing any dysregulation in these areas, it's important to consult with a medical toxicologist or your local poison control center. All right, next we'll look at disorders of ventilatory control. And the management is really dependent upon the cause. The management is uniform with other pathologies that we've seen previously. So put this patient on the pulse oximeter and cardiac monitoring. If there's a trauma situation, you'll want to stabilize the cervical spine. Assessing and reassessing neurostatus and vital signs is always important. And then always keep monitoring vigilantly for signs of impending respiratory failure and abnormal breathing patterns. These patients may need supplemental oxygen. And in trauma or even sepsis situations, you want to keep an eye on their glucose levels as well, as low glucose can be associated with increased morbidity in these patients. They may need IV access for hydration or other medications. They may have hypotension in the setting of shock or trauma, which will require isotonic fluid resuscitation. And they may develop pulmonary edema, either from intracranial causes or other secondary causes. So you need to watch for increased work of breathing, RALs on exam, or signs of increased fluid on chest x-ray. Again, you'll want to consult with your poison control center as needed because there are certain antidotes that do exist for patients who have apnea or decreased ventilatory drives, such as opioid exposure. The antidote would be Narcan or naloxone. So that concludes our lecture on respiratory distress in children for pediatric advanced life support. We will continue next with our next lecture.